Welcome to Leeds Fertility and the third in our series of videos helping patients to prepare for their IVF cycle. My name is Dr. Catherine Hayden and I'm one of the clinic consultants and subspecialists in reproductive medicine. This section discusses what happens in the laboratory after your eggs have been collected. This is a picture of the laboratory at Leeds Fertility, which is a deliberately dimly lit space to meet the conditions that the embryos wish to be manipulated in. It is absolutely essential that all eggs, sperm and embryos are correctly identified as belonging to the correct individuals. You can rest assured that we operate a system of manual identity checking by reading aloud your name and date of birth, and electronic witnessing, which double checks your unique barcodes. Before starting the egg collection, all team members will check and confirm your identity with you. You will also have a witnessing check at the time of the sperm sample. These will be the first of many witness checks to ensure that your eggs, sperm and embryos are correctly labelled and correctly partnered up. At each step of your treatment, both in the laboratory and when you are not present, and in the theatre when you are, two people will check your details and sign to confirm that they are correct. When the eggs are first retrieved, this is how they appear to the embryologist under the microscope. They're surrounded by cells called cumulus cells, so called because they look like cumulus clouds. The egg itself is about the size of the width of a fine hair. At the end of the egg collection, we'll be able to tell you how many eggs we have retrieved. Once we have seen the egg, we remove it from the fluid in the follicle and place it in a labelled dish in the incubator, where it is kept safely with the rest of your eggs until the time of the insemination or sperm injection. In standard IVF, the eggs are prepared and the sperm is also prepared, and they're mixed together on the afternoon of the egg collection in a process called insemination. Over the next 16 hours or so, one sperm will penetrate the egg and the fertilisation reaction can then take place. The need for ICSI, or intracytoplasmic sperm injection, is usually known beforehand. Occasionally, the sperm sample produced on the day of treatment is poorer than expected, and the decision to inject sperm is then made and recommended to maximise your chances of fertilisation being achieved. ICSI is generally done when there's a problem with the sperm, such as very low numbers, poor swimming motion, a high proportion of abnormally shaped sperm, or anti-sperm antibodies, or a combination of any of these problems. Sperm used for ICSI do not necessarily have to come from the ejaculate. We can use sperm retrieved surgically from the testes and also frozen sperm from a partner or a donor. It's important to understand that not all of the eggs retrieved will necessarily be injected. They must be at the right stage of maturity to have any hope of reacting to the sperm, and this can only be established when the eggs have been stripped clean of the fluffy cumulus cells that surround them when they first come out of the follicles. One sperm is injected into each mature egg. The injection process is very delicate and requires great expertise and sophisticated equipment. A human egg is the largest cell in the body. It's just visible to the naked eye without a microscope and is about the size of the point of a pin. It needs to be held still for the injection to happen diametrically opposite, as shown in this cartoon, and for real in the next slide. Some eggs, about 10%, will not tolerate the injection procedure and may burst in the process. This is often associated with poor quality in that egg and implies that it would not have had a high chance of achieving a pregnancy anyway. Pregnancy rates after ICSI are the same as after IVF. The fertilisation reaction happens during the first night. There is a window of time when it can happen, and once that window has passed, we know that it will not happen even if we continue to wait much longer. The definition of normal fertilisation under the microscope is the presence of two pronuclei, which you can see as circles in the middle of the embryo on the right of this slide. These represent the genetic contributions from the egg and the sperm to the new being. Usually, about 70% of normal eggs accept the sperm, whether they are inseminated with sperm in IVF or injected with sperm in ICSI. Any eggs that do not fertilise will be discarded the next day. You'll receive a telephone call from the embryologist the next day informing you how many of your eggs have fertilised and how many embryos we're now culturing on. Over the next few days, the embryos are incubated to allow them to grow and develop until the best quality one, or sometimes two, can be selected out for transfer into the womb. Embryos that reach the blastocyst stage of development, usually on day 5 of life, have a higher chance of attaching to the womb lining and producing a baby. If the number of embryos available to you is small, for example just 2 or 3, it may be clear which one is or which ones are the best before day 5 or the blastocyst stage of development. Embryos can be safely transferred on day 2 or day 3, and indeed this was normal practice 10 years ago. In this case, we would invite you in for embryo transfer at that stage because keeping the embryos in the incubator would offer no further advantage over the natural environment inside the womb. Leeds Fertility is pleased to be able to offer some of the very latest technology available. In conventional IVF culture, the development of embryos in between the fixed checkpoints of fertilisation, first division and day 3 are not seen or evaluated. The latest time-lapse imaging technology allows embryos to be observed throughout their early development by taking images of them every 10 minutes. The resulting video that can be reconstructed from these images can be rewound and examine the fine detail of the development occurring at any point, even from the middle of the night. The embryos are examined without having to remove them from the stable, closed system in which they're growing until they're required for your treatment and transfer. It is becoming apparent that some of the events that occur during these early stages are indicative of a higher or sometimes a lower chance of producing a healthy baby. The information is helping the selection process for embryo transfer and should increase the success rates over time. This technology is not covered by the tariff for NHS-funded cycles. However, all patients are offered access if they wish to use it and are able to fund the supplementary fee. You must make this decision before your nurse consultation and book your slot on that day with your nurse and by settling the invoice with the business support team. The machine has the capacity to house 12 embryos per couple. If you produce more than 12 embryos, the excess will be incubated in a standard incubator without time-lapse imaging. The next slide shows an example of the first 5 days of life as captured by the embryoscope. This is a diagram showing the possible fate of the embryos created from a generous harvest of eggs. In this particular example, 5 blastocysts have developed. 1 blastocyst is transferred, 2 are good enough to freeze, and 2 are discarded. Not all spare embryos are suitable for freezing. We will only freeze top quality embryos which have a good chance of surviving the freeze-thaw procedures. Poor quality embryos will never improve through the freezing process, and often they will perish and simply not be recovered. About 1 in 6 couples will have surplus good quality embryos to freeze. If the embryos survive the freezer in good condition, and over 90% of them do so, they have the same chance of producing a healthy baby as a good quality fresh embryo. There are some circumstances where frozen embryos seem to do better than fresh ones. This is an area of intense research at the moment, so frozen embryos should not be viewed in any way as second-rate. This diagram shows a possible outcome if the number of eggs retrieved is fewer. In this particular example, The best embryo is identified at the day 3 or 8 cell stage, which is when it is transferred. There are no spare embryos to freeze. On the day of your embryo transfer, you will receive a phone call from one of the embryology scientists who has examined your embryos. This will give you some brief information about the number of embryos available, their quality, and the recommended number of embryos for transfer. They'll advise you at what time to attend the clinic and when to start filling your bladder. Please be aware that the timings are approximate, as we won't always know by the time of your phone call how many patients will be transferring on that day, and it can change as the day progresses. We work like this to tailor our decisions to maximise your chances of success. We run a 7-day service to be able to transfer your embryo when you have the best chance of success. However, this can sometimes mean a little bit of waiting on arrival. You may need to empty your bladder and fill up again. Please don't allow yourself to get so full that you're in pain, as this makes the transfer more difficult if you can't lie still and be scanned through your abdomen at the same time. Please ask the recovery ward nurse about your time for transfer if you're getting uncomfortable. The next slide shows a video of the abdominal ultrasound guided passage of the embryo transfer catheter through the cervix and the embryo being gently expelled from the tip of the catheter at the upper end of the womb cavity. This is where the lining is at its thickest and implantation is most desirable. The toughest part of an IVF treatment cycle is the so-called 2-week wait after the embryo transfer until your pregnancy test is due. The recovery ward nurse will ensure that you're happy with the medications you must continue to use after the transfer has been done. Please don't forget to bring your diary with you. You can empty your bladder with confidence that any straining will not push the embryo out. Any fluid you may feel leaking will be from the vaginal cleansing procedure and not the embryo falling out. There is no need to rest or to take time off from your normal activities. In fact, carrying on as normal is probably the best way to make the time pass until the pregnancy test is due. We recommend a urine pregnancy test with the first urine passed on the morning of the 18th day after your egg collection. After the transfer, you'll be asked where you would like your test to be done. You may wish to do this test in the privacy of your own home. You can opt to have the test done at Leeds Fertility, in which case you should book an appointment and bring a urine specimen with you. If you choose to do a home test, follow the packet instructions. Please call us the same day to let us know the result and to receive further instructions. If we do not hear from you, we will contact you 24 to 48 hours after we expect to have heard from you. After a positive test, you may need to have some medications topped up. An ultrasound scan should be booked for early pregnancy assessment for 2 weeks later. A negative test associated with bleeding is sadly a true negative result. You should stop your medications and make an appointment for follow-up with your consultant after an interval of your choice. This appointment takes place at Leeds Fertility for NHS patients and at one of the private hospitals or by special arrangement with the consultant's PA for self-funding patients. The cost is included in the package paid by self-funding patients. A negative test without any bleeding should be repeated after 3 days, as it could be a false negative, as in a positive result that hasn't shown up yet. In the meantime, you should continue to take your medications. If the second test is also negative, the treatment has sadly not been successful. A positive result will need to be followed by an ultrasound scan appointment. Please call Leeds Fertility with the results either way and to receive further instructions. Between 6 and 7 weeks of pregnancy by conventional calculation, which is 5 weeks from the egg collection date, it is usually possible to identify the baby on ultrasound scanning and see the heartbeat flickering. In this scan image, the baby is enlarged and the actual baby is only about the size of a grain of rice. If all is well, you will be discharged from Leeds Fertility at this stage and invited to book in with your GP and your community midwife to start the antenatal care process. Our job is complete for now. We will be contacting you after your expected due date has passed in order to find out how things went and to let the HFEA licensing authority know the final outcome of your treatment with us. It is important that you maintain up-to-date contact details with us, especially if we have embryos or sperm in storage for you. This concludes Chapter 3.